is I'm a GP. I've been a GP in Streatham for a bit more than 35 years. I keep losing count. I'm really pleased to be here. Thank you for having me. Because I've known Chuck a little while. We kind of meet each other here and there. I suppose the last few years I've been a bit more involved in what you might call a community space as a GP, because I'm really I can see such potential and value in kind of linking up the community and healthcare and services and communicating and understanding things, and within, I suppose, the health community generally, we're also much more aware in theory about inequality and the impact of inequality. I mean, that has, on people's lives, but also on their health and their care, and it's a complex area, but and it's difficult to know how to settle it. But the new government, maybe the left cheek is just that little bit more helpful than the right cheek. We'll see. But and one of my failings is that it can be difficult. I can kind of go off on a tangent, but
you're in the right space.
So the chairman is welcome to pull me back. I'm also quite. I don't easily take offence. Feel free. So I think the thing I'm going to start talking about, I think, is about, I suppose, a kind of a pathway that how things might go when you're thinking about prostate cancer, and I'm going to say a couple of things. Sorry, very small digressions. One, if we get a chance later, I'd love to hear from you guys about. I've come across a couple of people lately who are stuck in their homes, scared of violence and going out, and if anyone's got some ideas about how those guys might be helped, that'd be great. But and then if maybe have a chat. Depending where you live and what, there may be a way to get you an NHS chiropodist. So let's.
My GP said I can't get it.
Okay.
But you can go if there is a way.
We're sure. So, but I heard you're not in Lambeth. So, but anyway, let's don't want to interrupt the group time. So Jacko kind of talked about accessing GP services, and I guess that's general, as well as specifically about prostate things. And I think so one thing that people may or may not know is that kind of technically, from some points of view, each GP practice is its own business, and in one sense is technically not part of the NHS. It's a kind of a private business. The history of that is that when the NHS was born in 1947 or whenever it was, the doctors were a powerful lobby, and they, on GPs in particular, and they didn't like the idea of being employed by the state, so they kind of had this deal where they're what we call independent contractors. Now, I've kind of got used to that, and I quite like it. In the old days, you could kind of be a bit awkward and not do what the government wanted. It's getting more difficult, but that's for the doctors to sort out. But what it does mean is that although there are more and more kind of performance indicators and things that different practices can organise themselves rather differently. But so I guess accessing GP surgeries, there's a good old-fashioned way of going into reception, which on the whole people tend not to like so much. But if you're polite, you can go a long way. Actually, just sidebar. Receptionists are all different people, they are given their orders by the doctors, so it's not always their fault when they're when they're apparently not helpful. On the whole, I think they enjoy helping people to kind of find the right way through. So I guess like a lot of things, if you find you can find a way to work together with someone, that's better. But equally, some days it just doesn't work. Anyway, so coming to reception, phones. I know. I I discovered recently at our practice, and it was slightly a surprise to me, but when I thought about it, maybe it's not such a surprise that the population registered with our practice are the least. We've got the least deprived population of any GP practice in Lambeth. In one way that's not surprising down in Streatham. Day to day, I see plenty of people who I would think are kind of on the wrong end of inequalities, but compared maybe to GPs working around here or Kennington, Waterloo, Seven Corners, and I've always liked to think it's because we're well organised that people don't usually wait long on the phone if they call us up, but it may be something to do with that. But so I know the phone can be difficult, but that's the option, and again a number of practices will kind of operate a system. I'm sure people know this. They may have found it that you need to ring up at 8 in the morning, and if you ring up at 8:30 and say, "Can I see the doctor?" they say, "I'm sorry, we've got no appointments."
My surgery has just changed that, and you can now book online up to 2 weeks. Hernial group practice. And just a helpful question you might find in terms of a survey: is everybody in here registered with their local GP?
Mm-hmm. Yeah. I've got that survey
So kind of online options are kind of more available. So one thing that you mentioned is about making appointments online, and I guess individually as a practice and GPs generally and the NHS generally are quite keen to promote the NHS app, and if you do have the NHS app, you and I don't know if this is the way you do it, there can be other ways. That's one way you can kind of go online and actually book an appointment. And again, the precise details of how that works can vary a bit from practice to practice. Incidentally, on there, you can also everything that, well, more or less everything that the doctor or anyone else puts in your records from, I think, the 1st of April onwards, that is in your record, you can now look at through the NHS app. The reason why it's not earlier than and again, depending how things are set up practice by practice, there'll certainly be some information you can look at prior to April, but it's not necessarily absolutely everything, because doctors are a bit anxious about some things they might have written in the records. But incidentally, on that point, I'm sorry but I'll try and keep going. You always have a right to say, I'd like to see a copy of my records, and as I like to say, they're your records, they're not the doctor's records.
This right, does it come from good practice? Is it written anywhere?
Yeah, it's apart from the Freedom of Information Act, which is there, it's always been the case, certainly in the last 35, 40 years, that if you say, can I see my records, and in the old days we could sort of say, oh well, it's kind of difficult, there's a lot of them, we have to make a copy, it's going to cost money. Potentially now someone can just email you the whole lot, so there's no excuse, and hopefully we don't make excuses or put barriers. There is an exception that if the doctor thinks that there's something in your records that would be potentially bad for your health to know. The typical example might be, and it's quite rare that this actually happens, might be that say that the doctor's thinking about some serious diagnosis but hasn't talked to you about it, and they don't want you to find that out by just reading it. You know, sometimes when you're kind of thinking, well, it could be this, it could be that, it's not always helpful to have too much of a conversation, even though, I mean, in my experience, usually the person who's come to see me is actually already worried about something, so you might as well talk about it. But that's a different issue. So, sorry, online services. So again, all practices now will have some sort of opportunity where if you go to their website, there'll be something you can click on, and you can send in some sort of inquiry. You know, I've had a rash for such and such a time. You should, by one means or another, be able to send a picture, or you know, I've had back pain or whatever it is. This is happening, and that can be quite a helpful option. I mean, I guess particularly for something maybe where you feel it's not super urgent, but you kind of want to get some feedback about it. And I mean, sometimes, for instance, if you kind of said, well, I've had this back pain for a while, and you might get a message back, kind of saying, okay, well, we'll sort out an appointment for a physiotherapist, which is so then you might have a feeling that you're being kind of battered away,
So can I ask you a question? Just jump in there a little bit now. When I come to you with a back problem, okay, what's the average time one needs to wait before I come to you with a back problem before I see a physio? What kind of time are we looking at here?
Okay. Well, so in that particular example, again, at the moment, most, if not all, but most practices in Lambeth actually have a physiotherapist working in the practice, which is part of a scheme that's been going on the last few years to get kind of more other professionals working closely in general practice, in primary care. And I mean, part of the reason for that is it's not, that some of the ideas in particular are quite good, like having this physio in the practice, but also, as you may be aware, there is a kind of, for various reasons, a shortage of GPs, and be thankful that we're not living in some certain other parts of the country where the shortage is worse. But and because of the shortage of GPs, that some other people, in particular pharmacists, physios, who have a lot of skills and kind of knowledge, can actually be helpful with a lot of things. But so so I think and the physios who work in the practices will give a kind of a fairly short, sharp assessment. It's not a kind of a full physio assessment and kind of treatment program, but they'll generally be available within, say, 2 weeks or so, but they'll do quite a focused assessment of the problem, they'll kind of work out if there's anything kind of serious or nasty underlining it, which is important, particularly say with back pain, or and they'll give you some kind of advice about stuff that's likely to be helpful. And then usually they'll also give you information about, if it's not, they'll sort of say, if it's not getting better after 2 weeks or 4 weeks or 6 weeks, here's some information about how you can make a more formal kind of refer yourself to the physio. And I mean, that waiting time for that will be maybe 6 or 10 weeks for that more. Not sure what to call it. Part of wants to call it proper physiotherapy, but that undermines because in fact the people who you will see in the GP practice will be relatively senior physios, relatively experienced, because they're in that situation of making a broad assessment, and so for instance, if
are you saying you do the assessment, the physio and the GP does assessment, if it's really serious, then it goes to the physios in the local hospital, is that what you're saying?
Well, yeah. Well, I mean, if you take the example of back pain or knee pain, which or two quite common problems, you know, most likely the physiotherapist will sort of say, well, look, these exercises are likely to help. Try these for, they might say 2 weeks, 4 weeks. If it's, you know, if it's not improving, then, you know, see this other person. Now, in terms of, I mean, I mean, on the whole, you know, even if the pain is quite bad, it's having quite a big impact on, you know, what a person's able to do. You know, there may be one scenario where you can be quite optimistic it's going to get better quite quickly, and another scenario when it's not so much. It may be that the physio says, okay, well, look, we'll do a referral now for, you know, what you might call a formal course of physiotherapy, but, you know, in the meantime, whilst you're waiting, do this. And if these senior physios are able, if you know, if it seems it's going to be helpful to arrange an X-ray or even an MRI scan, because there are a limited number of times when that can be helpful, but you know, they're able to do that if.
What kind of patient going? You're saying?
Sorry, how much experience does an associate practitioner have to have? And if they get it wrong, how liable are they?
Right. So to be on it. So when you say an associate practitioner,
just someone who's not a GP.
Yeah.
Looking after you within the surgery.
Right.
Seeing you and
okay.
diagnosing you.
Well. So there are. I suppose there are a number of different people, and the answer slightly depends. So I mean, so physiotherapists, pharmacists, are nurses.
Yeah.
There's quite a strong regulatory framework, you know, about the training that they have to have, the ongoing training, you know, since they first qualified. If they've done something wrong, you know, potentially they can be kind of have their kind of registration or license, whatever you like to call it, withdrawn. And so, I mean, there is a little bit of discussion, and I mean, in our practice we don't use these people particularly. How
about trainee doctors that are unsupervised seeing you?
Well, so yeah, so when doctors kind of finish medical school, they the first 2 years they work usually in the hospital, occasionally in general practice, and they're always kind of quite closely supervised. So that's kind of like, say, a probationary period.
Okay.
I mean, at that time they're registered with the General Medical Council if they you know, if they mess up badly, or you know, if they're, you know, they start saying racist things or rude things, or you know, so doing the wrong thing in any way, you know, potentially they can be disciplined. Then they're, once they've done that, they're fully registered, but they're doing their specialist training, and there's a kind of a mechanism which is kind of monitored, but there's room for kind of individual variation, where people gradually do more and more with less and less supervision, or less and less direct supervision. So in GP practice, there are GPs who are called registrars, who usually they've done those first 2 years. It'll take them kind of a minimum of 3 years to become a fully trained GP. So you might see the GP registrar. That GP registrar has a trainer who has to be present in the surgery all the time that they're consulting. So if they're not sure, they can ask. They'll every week they'll have a kind of like a supervision appointment time when partly they're doing training, partly it's an opportunity to talk about things.
They're not in the same consultation space at the same time.
Well, so if they've got the opportunity to say, you know, okay, Mr. Smith, told me this, I just want to go and check with one of my colleagues. And as I say, the regulatory framework is that there has to be a trainer, not necessarily just another GP, but a trainer who's there in the practice that they can kind of go and knock on the door and say, look, I'm not quite sure what to do about this, or whatever.
If the trainer is on leave and you have a locum who's not a trainer, and you have this, let's say, junior doctor, what happens then?
Well, so I mean that's a good question. I mean, part of the answer to the question is it doesn't happen all that often. I mean, nowadays, we're nearly the smallest practice in Lambeth, and most days we'll have 3 to 5 doctors in the surgery, at any one time. In our particular practice, we've had 2 GP trainers, and it doesn't suit us anyway for both of them to be off at the same time, so it kind of doesn't happen. I mean, I'm not a GP trainer, officially, but sometimes the registrar will kind of ask me a question because the guy who's the trainer is actually with the patient at the time, and it's kind of easier to ask me. And so, although that's the framework, you could say it's not. You could maybe find some leaks in it, and I'm sure in the day-to-day situation. But I think it's. From my point of view, it seems safe because I've been operating that system for a long time, and people, as I say, there's this kind of graduation where, all of us.
So I'm going to have to stop you there because we're kind of
getting off into a different area.
I just want to focus on when of us guys go and get a blood test, the results. What's the importance of having a blood test? Let's start with that one. We can kind of break down, the results and what does it highlight in terms of our health.
All right. And just to clarify, you're talking about blood tests generally, rather than prostate.
The MOT one.
Okay.
In terms of what the results come out, what you expect out of them, where you can take it to make the results a negative.
Okay.
Or positive.
Yeah. So I guess talking about an MOT, the thing that one might be coming across is what's called an NHS health check, which I always feel, sometimes I feel a bit conscious that in a way it's not maybe as sophisticated as people might think, but I think potentially it's certainly useful, and the NHS health check will kind of focus on a number of things, and part of that will be some blood tests, and the blood tests will be to check your kidney, check what's called the full blood count, which is the red blood cells, white blood cells, and platelets in the bloodstream, cholesterol, and HbA1c, which you probably know is a kind of related to blood sugar indicator of diabetes. So that those will be the tests that will regularly be done. What will generally happen, ideally you arrange to have the blood test before you have the face-to-face health check. Sometimes you may kind of see someone face-to-face, have the blood test, and then have another discussion later. But so the kidney blood test, kidney disease is not common, but it's important. It is higher in the black community. It's quite often related to diabetes. Your kidney function, we've got quite a lot of spare kidney function, so our kidneys can get quite bad before we actually feel unwell. But as I say, most people, most of the time, kidney function is fine, but that's one of the checks. The full blood count is a bit of a, it's very broad. There's so many things that can affect it, but if you talk about the red blood cells, these are the ones that carry oxygen. If there's not enough of them, or there's a problem, then generally you'd be said to be anemic, and there can be a number of reasons for that. And in a way, if we find a person who's anemic, we want to think, well, why are they anemic? Do we need to worry about the reason for it? What's the treatment to make them not anemic? I guess that, as I say, also relates to the white blood cells and platelets. I mean, on the whole, at the NHS Health Check, 99.9% of people, that's fine, but you know, a problem can crop up. It's worth just saying about blood tests that there's always a normal range, but I do this because quite often a result will come back a little bit out of the normal range, and the doctor will say, doesn't matter, and that in one sense you're kind of asking a person to kind of trust the doctor, and there might be some reasons in a particular situation or generally why you might not feel like trusting the doctor. You know, it's obviously appropriate to sort of say, well, you know, why do you say that? What there are some results which seem to very often come back kind of slightly out of range. So the normal range is a kind of statistical thing that 95% of the, if you do 1,000 or 100 or 1,000 blood tests on people who are well, this is the range that will fall in 95% of the time. So you know, it's a bit like if you know, if someone is 6 foot 6 inches tall, that's not normal. Doesn't mean there's anything wrong with them. They're just a little bit exceptional. So yeah, just put that in as a so where are we? So I guess the things that we focus on more cholesterol and HbA1c, diabetes. So cholesterol is you know, everyone knows it's a bad thing.
It's fat in the bloodstream?
Say again?
Is it fat in the bloodstream?
So it is fat in the bloodstream. There are a few different kind of subtypes of cholesterol, or to put it another way, the way cholesterol, so cholesterol is one particular chemical which is kind of fatty, you could say. It's carried around the body in certain different ways, and there's something called HDL cholesterol and LDL cholesterol. But the main point of kind of measuring it is as part of looking for a particular individual, what is this person's risk of having a heart attack or a stroke? Are they at high risk or are they at low risk? Now, a person can have a relatively high cholesterol, but if all their other risk factors are good, actually their overall risk may not be all that great. It'd still be good if they could get their cholesterol down, but so it's not always a simple matter to sort of say what, you know, what's a normal cholesterol or what's an ideal cholesterol.
Can we break it down? You said the low density and high density. Can we just break that down, because sometimes your high density, low density can kind of push the total up. So can we just break that down, the difference between the low and the high density, what it actually means? Because you'll have 3 different, and the triglyceride.
Okay. So the triglycerides are a different type of fat. They're not kind of closely chemically related to cholesterol, but and they are relatively rarely a problem. But particularly in some families, some people have a very high triglyceride level, and they have kind of a higher risk, and the kind of treatment for them is a bit different. We're talking about cholesterol. So I mean, there's over 30 years that there have been at different times, there's different kind of expert opinion about which is the really important thing to look at. Is it the total cholesterol? Is it the HDL, high density lipoprotein cholesterol, HDL cholesterol, which is important? Is it the low density LDL cholesterol? Is it the ratio between the HDL and the LDL, or the ratio between the HDL and the total? They're all different. People kind of analyse it, look at statistics, because what they're looking at is like thousands of people in, you know, if you say, yeah. So at the moment, the kind of fairly recently, the general guidance, the general agreement, and hopefully this is some kind of consensus that's going to last for a while, is that the LDL level is the important one, and the lower the LDL the better, and the higher the LDL the more your risk. Now if the LDL goes up, your total cholesterol will tend to be higher. So the total cholesterol is a kind of general indicator. The HDL on the whole, if you have more HDL, that's a good thing. If you have more and more and more, it gets to a point where where the extra isn't quite such a good thing. I mean, it's not a bad thing, but to kind of keep it simple, the LDL is the important one, and again, the lower it is, the better. But we have a kind of a system to look at. I mean, mainly looking at height and weight, blood pressure, family history. When I say family history, I mean, you know, have you got a father, mother, brother, sister, so a close relative, who's had a heart attack or stroke below the age of 60? So I mean, for instance, if your father's had a stroke at 70, I mean, that's bad news, but it kind of, it's not so unusual that it makes my risk higher. But if he had a stroke at 55, that's a bit unusual. That statistically, that means I've probably got a higher risk. If it's my cousin who's had it, that my cousin's only got, my parents and brothers have got 50-50 the same genes as me. My cousins, my aunts, my aunts and uncles have got a quarter of the same genes, but the cousins have got like an eighth of the same genes. So it doesn't matter so much. So where are we? So height and weight, family history, blood pressure. One thing. So during the health check, the person doing the health check will generally ask you about how active you are, there's thousands of studies that show that the more, if you compare two groups of people who are very similar, but this group are more active than that group, then your risk of heart disease or stroke is about 25 to 30% less if you're more active. For a reason I'm not quite clear about, the system we have doesn't take that activity into account. I suspect it's in a way because it's a bit difficult to measure activity, because I mean, just walking a little bit here and there count as much as doing housework intensively for 2 hours, or having a job as a cleaner, or having a job as a gardener, or or being a kind of a keen cyclist, or it's kind of a bit difficult to measure. Anyway, so that's something that's not in the formula. Blood pressure, family history mentioned. Height, weight, smoking. Smoking's obviously important. Smoking rates have declined a lot. I mean, 30 years ago, about 45% of the population smoked. Now, about 25% of the population smoke. Still tends to be people who are less well off who smoke, and
the very wealthy.
Yeah, well, there is apparently a trend in wealthy women, wealthy young women, to be smoking more. But anyway, that's yeah. So it talks about cholesterol, it talks about cardiovascular risk. When I say so with cardiovascular risk, that's a long way of saying your risk of heart disease and stroke. Heart disease technically we're meaning either having a heart attack or getting angina. Angina is when there's not quite enough blood going to your heart for the amount of activity you're doing. So you may find if you're sitting in a chair, your heart's getting enough blood, and that's fine. But if you run up the stairs, your heart's working harder, it wants more oxygen, it wants more blood, but that blood can't get through. You get some pain, in your chest, or possibly in your arm, or possibly up here, and that's kind of like a heart pain, but it's not a heart attack, because when you stop it, the pain will usually go away quite quickly. So heart disease covers kind of the angina, and a heart attack is when there's so little blood getting to the heart that some of the heart muscle that is being kind of looked after by that blood vessel, the heart muscle dies, which is kind of painful and cause other problems.
No, I didn't.
Okay. Oh, right, beg your pardon.
So with the health check, it gives you a snapshot of where you are in time.
Yeah.
So therefore, in order to actually find out a trend, should it be done yearly?
So the program is to do it 3 yearly, because the kind of statistically, things don't usually change all that much over a year. So it is a snapshot, but I guess the things that we're measuring don't necessarily change. So I mean, for instance, blood pressure. It's a good thing to talk about in a room of black guys, because I'm sure you know, high blood pressure is commoner in the black community, and the risk of stroke. I haven't been to the stroke ward in King's myself, but people who have tell me that most of the beds are occupied by black people, and that is, and about a quarter of Lambeth are black people. So if more than half, that's a problem. Stroke is quite a rare, uncommon. Most of us might know. I mean, well, certainly more people with diabetes than people with strokes. We'll know more people. Statistically, we'll tend to know more people with heart attacks than strokes. But I mean, a stroke is kind of like a disaster, really.
I'm going to just rewind a little bit. You know, when you talk about blood pressure is 120 over 80. Can you kind of describe a little bit what the 120 is and what the 80 is? And what, when people do the blood pressure, what are they looking at? If it's like say it's 190 over 80, what are they looking at here?
Okay, so everyone knows your heart beats, and then obviously it relaxes in between beats. So the pressure in the blood vessels, when the heart beats, the pressure goes up. The kind of pause between it goes down. The blood vessels are not like, so I'm looking for radiator pipes, but they're not copper radiator pipes. They're kind of a little bit elastic. So there's a little bit of give. And anyway, so the top number, Chuck talks about 120 over 80, which is if someone says what's the normal blood pressure, someone say 120 over 80. That's but you could sort of say that's so that's more or less an ideal blood pressure. So it's the heart pumps, it's 120, resting between it's down to 80. We took the kind of technical word is the systolic and the diastolic, because the heart is pumping, that's called systole, and when it's relaxing it's called diastole. So systolic and diastolic. So right. So the kind of definition of high blood pressure is higher than 150 over 90. So if you've got a blood pressure of 148 over 88, that's not officially high blood pressure. Having said that, if you take 1,000 people with a blood pressure of 148 over 88 and 1,000 people with a blood pressure of 118 over 78, and you kind of keep an eye on them for 10 or 15 years, the ones with that slightly higher blood pressure will have, it's quite a small effect. I don't want to overemphasize it, but it's an adverse kind of factor. But the nowadays we tend, if we find someone, we check their blood pressure once or twice and it's a bit high, what we we'd usually do is arrange a 24-hour blood pressure measurement. So this is a gadget that you put the blood pressure cuff on your arm, you have a little box that you put in your pocket or hang on your belt, and then it will automatically check your blood pressure every half an hour or so. I mean, maybe half an hour in the daytime, every hour at night time. It will check your blood, and that way it will get about 30 readings. Because the thing is that we on the whole we wouldn't know it, but our blood pressure can vary quite a lot. You know, just so I was wearing one of these gadgets once, because we just got one about 15 years ago, and I thought, well, let me try it out, see how it feels. I happened to be cycling up a hill when it went off, and my blood pressure at that particular moment was, I can't remember exactly, but it's something like 200 over 100. But my average blood pressure was fine. When I was asleep, it was, I don't know what it was, but it might have been 100 over 70.
Can I just quickly ask, what's the dangers of borderline blood pressure?
The danger of borderline?
Yes, is there a danger of borderline?
Well, so as I've kind of said, there are kind of, within reason, the lower the better,
yes.
and the higher the less good. So if you have a kind of like a borderline blood pressure, by which I would kind of say it's not, it doesn't kind of tip over that threshold of being abnormal, but it's near, then there is a small, and it's kind of statistics. One of the problems is, in a way, this is all statistics. So you can meet a number of people who statistically might have a slightly higher risk, but not all of them will actually experience a stroke. But so if you have borderline blood pressure, if there is something you can do, and we'll talk about that in maybe a few moments, to help the blood pressure to come down, and also to kind of address the other risk factors. So just going back to this idea about the blood pressure kind of varying, because I mean so the reason we take an interest in blood pressure, as I say, is because it increases the risk of heart disease and stroke. So the way that it does that, you've probably heard of atheroma or atherosclerosis or arteriosclerosis. Okay, very good. So that's a fancy word for hardening of the arteries, or your arteries furring up. So again, just to say, when the blood is going from the heart to the tissues, those are the arteries, those are the blood vessels that are carrying the blood to where it wants to go. The blood vessels that are bringing it back are called veins. So in this context, the ones we're interested in are the arteries. If the arteries are clogged up, furred up, narrowed, this process of atherosclerosis has been happening, then there's less blood getting through. And with a heart attack or a stroke, what tends to happen is over many years, literally decades, then it will get narrower and narrower. It will get to a certain point where the flow through is so slow that it'll just stop. It'll just clog up, and because a little blood clot will form.
I was just about to say the furring could release a blood clot, couldn't it? The lining on the fabric that is created by the thickening, couldn't that break off and make a blood clot?
Yes, to the brain.
Right. So it doesn't generally. I mean, it potentially it can do, but that's not usually a problem. As I say, it tends to be that things just slowly getting narrower and narrower. Now, so there are a number of factors that will make this narrowing happen. So one, if the cholesterol level is higher, or the LDL cholesterol in particular is higher, then you tend to get fat, cholesterol kind of deposited in the lining of the artery, and that kind of contributes. If the blood pressure is higher, for reasons that, to be honest, I don't know. This is why I'm a GP and not a kind of a cardiovascular specialist. But high blood pressure over years and decades, not over minutes and days, will tend to accelerate it. So the average blood pressure is more important than certain fluctuations. Smoking will the chemicals in the cigarette smoke will, well, A, they'll tend to make the arteries narrower. B, they'll tend to cause more inflammation, irritation in the membrane inside, which will make it more liable to damage and kind of the inflammatory processes.
When you say smoking, are you including vaping, or are you including burning anything that you actually breathe through your lungs?
Okay, so there's really strong evidence for smoking tobacco, and there has been since something like 1965 was a study that was published, and yeah, I mean there's a sidebar about why actually doctors, as well as everyone else, were quite slow to believe it and take it on board, but that's another story. Vaping, so because people have only been vaping for a few years, the rigorous scientists will say, well look, actually we don't really know how bad vaping is, but the small amount of evidence that there is that it's not as bad. It's certainly not as bad as smoking tobacco. Now, also theoretically, we would assume that the tobacco is more dangerous because over the years people have identified. People say hundreds. I'm a little bit sceptical about that, but certainly tens of chemicals in tobacco smoke that can have various harmful effects. But you know,
sorry, can I just go on a bit? You talked about the systolic and the diastolic. So this systolic, which is the top part, is high. That means your heart is working overtime, and does that mean that there's more blockage in your arteries? Is that what you said?
Yeah, let me see.
Because
so
the bottom one is the rest period. The diastolic is the rest period, isn't it?
Yeah.
It's just boom, and it rests for a while. And this one could do, and this is the
kind of peak, as it were. Well, I suppose taking the example that I gave of when I was cycling up the hill and it was 200, I mean, that if my blood pressure was always at that level, that's putting a lot of strain on the system. But you know, the system is designed for, you know, exercise. You know, on the whole, exercise is good for us. On the whole, people who exercise regularly more will tend to have a slightly lower average blood pressure. So when they're resting and so on, it will be lower. The kind of mechanisms that lead to high blood pressure are quite complicated. So one part of the mechanism is the heart beating. Part of the mechanism is how, I talked about how the walls of the blood vessels, the arteries, are a bit elastic, not like copper piping. So if they're more elastic, then when you pump, the blood pressure will go up and it will kind of bounce down again. But if they're quite, if the blood vessels are more rigid, which tends to happen with this atherosclerosis, then for a certain amount of the heart pumping, the pressure will go up more. Also, what makes it complicated is that the body has various mechanisms to kind of regulate and modify the blood pressure, so the body can make the blood vessels a bit tighter or a bit looser. It will also, through the kidneys, there are some hormones which will tend to make the blood vessels a bit lighter and a bit tighter and a bit looser, which are kind of regulated largely in the kidney. Also, the kidney will affect how much sodium is in the bloodstream, and if there's more sodium, which is what's in salt, then the sodium tends to draw water into the blood vessels and into the system, as it were, and that will also tend to make the blood pressure higher. So it's quite it's kind of, although we kind of talk in mechanical terms, it's quite complex. So
yeah, I had a couple of questions. It seems that fat cholesterol is responsible for building up the plaque in the arteries. Are there foods you can recommend that reduce it?
I'm going to come back on that. what, because you said it's predominantly in the Afro-Caribbean community. So have you identified what foods in the Afro-Caribbean are causing?
Well, that's assuming that everyone in the Afro-Caribbean community eats the same food.
Well, no, I'm just saying statistically says we're more likely to have high blood pressure. So I'm trying to see if is there a particular type of food.
Can I add to that, please? Can I just, this might be important. I remember smoking heavily, gradually smoking heavier and heavier, until I started getting cramps in my lungs. You see what I'm saying? And then when I give up the smoking, I put on a lot of weight, but I felt a lot better within myself. The cramps went away. I was able to run for a bus, which I couldn't do when I was smoking, even though I was a lot slimmer. And I was able to do a lot more exercise. And eventually the weight went down. But I think it's because of the smoking, I'm left with maybe a bit of diabetes, borderline diabetes, maybe.
So, we're complicated. The way we're put together. I mean, it's one of the it's kind of gobsmacking things about studying medicine. But smoking is bad for us in so many ways. I mean, we talked about the heart.
Yeah.
It's also bad for the lungs.
Yeah.
In a different way. Also, incidentally, the chemicals in smoking can increase the likelihood of most types of cancer. Not all types of cancer, not just lung cancer, but most types of cancer are commoner in smokers as compared how much commoner can vary a bit. But I'm sure. But I mean, you've highlighted a couple of things about smoking. One, that that whilst you're smoking, the chemicals can affect the lungs in such a way to reduce the airway's capacity and not always give you discomfort, but affect your breathing. And when you stop, it can quite quickly get better. What can also happen, not to everyone, but a proportion of people, there can be progressive damage that won't be reversed that can happen. So people with what we used to call chronic bronchitis, we now call it COPD, chronic obstructive pulmonary disease. Those are people who, generally because of smoking, not always, but generally because of smoking, they've suffered kind of damage to the lungs. Most people who stop smoking do tend to put on weight, and there are complicated reasons for that. Partly smoking tends to reduce the appetite, but also it has other effects. High five to you for kind of getting on top of the weight, assuming you're not smoking now.
No, not for a long time.
That's good, but it's interesting that just by putting on the weight you felt better.
No, I didn't say because of
but despite.
It was an adverse effect. I was compensating because I didn't know what the F to do when I wasn't smoking.
Yeah.
So I just ate.
Yeah, well, that's common. And it's a reason why some people don't want to give up smoking, is because they know they're going to put on weight and they don't want to. So particularly perhaps among women, better or worse, but let me see. You asked a question about food. Yeah. So I mean, talking about diet, I suppose I wouldn't say. Well, so I think on the whole, healthy eating. You can break it down kind of more and more and more, but putting it simply, eat more fruit and veg, eat less fat, eat less sugar. That's so. If so, I mean, I know quite often in people who are cooking Afro-Caribbean food will put quite a lot of oil or other fat.
Rice, potato on the same dish.
Yeah. So so kind of fat is something that you can cut down.
Eat good fat like olive oil.
So if you're going to have fat, olive oil is better than
groundnut
oil or lard, kind of fat from animal origin, but it is still fat. So I mean there is people speak about the Mediterranean diet where people and Mediterranean diet also includes a lot of fresh fruit and vegetables. so without a doubt, some oils are better than others. So the kind of, apart from olive oil, the kind of cheaper kind of good oil is so-called. Hang on.
Rapeseed.
Thank you. It is rapeseed. I was just trying to remember if there was a different one I was trying to remember. But rapeseed oil, which is which actually is one of the commoner oils if you just buy vegetable oil. So, but alongside the type of oil, kind of cutting down the amount you have. So I mean, if someone's, I think quite often when people are cooking, they'll just kind of put in this much. So it can be helpful to sort of say, okay, well, how much am I putting in at the moment? Let's say it's 6 tablespoons. Let's put in 4 tablespoons. The food isn't going to taste much different, but you're doing that.
Does taste different.
But well, so if you put in 2, so anyway, you.
Well, with the air fryers now, you can just.
Well, so
I mean, I'm just going back on that bit about you said like you know, in Caribbean cooking food they put a lot of fat. You say they put a lot of fat and salt.
But a lot of people go to Kentucky.
Can I just go back because we're going into statistics, aren't we? Statistically, we're more likely to have high blood pressure. Statistically, we're more likely to have prostate cancer. Statistically, we're more likely to have bowel cancer. And what is the other statistic? There's another one.
Diabetes.
Diabetes. Thank you. So diabetes, high blood pressure, are all related to lifestyle. So out of these studies, are these studies saying the foods that we are consuming or how we're preparing these foods are not good for us? Because we talk about the Mediterranean diet and we talk about as though the Mediterranean diet is seen as the god of all diets. However, when I look at the GI index, things like plantain and all that, they're quite good for people with diabetes. So I'm trying to understand with this research, what specifically are we looking at? Because the food itself, from my limited knowledge, doesn't seem bad for you. Therefore, I'm putting on the preparation. So, is that what's the?
Yeah, well, yeah. So I think you're right because I mean I've never had the privilege of going to Jamaica. I'm looking forward to hopefully my retirement. I mean I say Jamaica because I've kind of met a lot of people from
Well, it's the best
Jamaica.
place to go.
Let's not go down that road right now.
Oh, sorry. Right, but you know the place is full of fresh fruit and veg.
Exactly.
So you know preparation is important. I mean I think that there's evidence there is evidence that you know people of Afro-Caribbean heritage do have on average a more genetic susceptibility to some of these problems. One theory about that is that that there's a kind of an evolutionary kind of benefit to being able to eat a lot of food when it's around and kind of store it, which can mean you're more likely to put on weight. But then you're storing it, and then it's taking you through kind of times when there isn't so much food around. You know that's a hypothesis. There's a lot of hypotheses, lots of different things, and there's some evidence. I mean, particularly I think in the Asian community, but about kind of like the first and second generation that come to a kind of European lifestyle get more kind of problems than the kind of third and beyond generation, or they're more they're kind of the Western lifestyle, for want of a better phrase, kind of seem to have more impact on those things. So I mean, there's a lot of stuff which I think is you know discussed and it's not certain, but I think what I want to say in a way I think it so I'm sure preparation in the sense of you know that when it's arriving on the table, you know how much fat is in there, how much salt is in there, and I mean those are kind of the main kind of baddies that might be in a savoury meal, but you know there's also sugar to think about. I mean you mentioned rice and potatoes. Obviously these are carbohydrates. Now we need some fat. You know, it's our nerves are large. There's a lot of nerve tissue is made from fats, and
brain tissue.
And so we need some fat. We need. I mean, carbohydrates is the fuel that our brain works on and our bodies work on. So we need some, but we don't necessarily need this much potatoes and this much rice and this much pasta, and you mentioned kind of GI references. Just whilst I'm talking about carbohydrates, I suppose there's kind of like whole food stuff. You know, tends to be better. There's kind of a more gradual absorption of the carbohydrate, which is better for our system.
Can I just say, this is from presentations, from what presentation Danny gave. It's a conversation from a friend of mine that he had with a medical person, and I'll get right to the point of it. And it's frowned upon in our community. Now, if you masturbate regular, could you reduce the risk of getting prostate cancer?
Don't know.
Okay. Because the reason I brought it up is because I remember in our community, okay, I know that it's frowned upon to have a wank. You see what I'm saying?
Yeah.
But I've been around the white community. Not raised, but I ended up in the white community due to, I won't go into that, okay? And they do it all the time. And then half as, no, this is.
The only reason why I'm laughing at this is because last week we had a guy coming and he said it's wrong to, what did he say?
He was talking about semen retention and and the benefits for that.
So I mean that's it, but that's a whole different. It's going back in the days when they say like, when you get old you should have sex all the time. So then the whole idea of men getting prostate cancer was blamed on their wives or their partners because they weren't having sex as often. It goes along those lines, and I think we've come across to that conclusion that it has no relevance at all to prostate cancer. But if the white community want to wank all of that, that's their business. If the black community don't want to wank, that's also their business.
Yeah.
But if they do, it doesn't matter who does it, whoever. But the point is that scientifically it has no relevance at all.
It doesn't have no relevance.
To prostate, because the prostate itself in Afro-Caribbean men is actually a bit larger than is that right? Than in white men.
Yeah.
So there's a difference in size anyway.
Oh, okay.
And that's probably came into the whole thing about black men having a bigger dick than white men. Probably come from the actual prostate itself.
Oh, okay.
So the masturbation thing is completely. Daddy's still in shock, but
No, I'm thinking, when did I talk about masturbation? I don't remember that.
No, what you said was that when you was going through your rehabilitation after you had the operation, that the nurse encouraged you.
Right, but
to
that,
exercise.
that was because
Yeah,
that was
I'll
a
explain.
flow. That was a
Yeah.
flow, but that was a flow because after surgery, my friend.
Yeah, that was
not
post-surgery.
because that's not a preventative.
Yeah.
Oh, okay.
That you never said it was a preventative.
Well, he's been pulling himself off and he's
You know what I mean?
His hand is gone limp now.
No.
don't blame him for overdoing it.
Well, it's good to be able to go over stuff. It's kind of like a lot of information that's presented.
I do have a question about
Sorry.
the studies you talk about. So, when you get making these, when these frameworks or these boundaries are set up, what is the mix of the people in those studies? And has there been any studies where it's 100% of the black cohort to sort of say, this over this period gives us this? Or are we taking the UK population and all your studies are based on the same percentage numbers? Because you've mentioned studies quite a few times. And what I'm thinking of, statistically, if I wanted to test diabetes in the black community, but my testing was 100% Caucasian or 100% Asian as in Indian or 100% Asian as in Chinese, and I use that as a basis, isn't the fundamental question on the set incorrect? So how does that work?
Well, yeah. So I mean, I think I'm probably not going to answer directly, but hopefully what I say is relevant. I mean, I think the medical scientific community, forgive the expression, are kind of on a journey about thinking about that. And if you want to be generous, you can say, you know, they've been acting in good faith, but just not very bright. Or you could say, you know, say all sorts of things. I mean, leaving aside, you know, certain examples of kind of sickening experiments that have been done in the past in a racist way. But I suppose thinking about those things. So I mean, I think and again, partly I'm not giving you a direct answer because I'm not sure of my facts. But I certainly, I mean, some of the blood pressure studies and other what we call epidemiological studies that, you know, looking at, both kind of looking at whole populations, but also looking at, you know, okay, let's do a study on 1,000 people or 500 people and see what happens. I guess even back in kind of 30 years ago, people would generally, they wouldn't necessarily recruit particular groups of people, but when they published the results, they would kind of specify that, you know, that X% were kind of black, Afro-Caribbean, X% more white, and you know, very often, you know, there'd be quite a low proportion. I mean, I have no doubt that there have been some studies done which have been entirely on the black community, but I you know, I can't kind of give chapter and verse. So I think you're right to, or what you say, I think highlights that there can be a flaw or a potential flaw in some of the evidence, and it's, you know, it's good to ask those questions and kind of unpick it a bit. But I, as I say, without a doubt, people are, you know, becoming more aware of this as an issue. And I think generally, I mean, I've heard it said that, and I forget the statistics, but as human beings, we've got something like 80 or 90% the same genetic component as bananas, and that may well be the case, because I mean, there's so many kind of chemical processes that go on inside us. But I mean, that's a trivial thing. But I mean, from my point of view, there's a whole lot more genetic processes that are the same between me and you than there are the ones that are different. You know, without doubt, there are some that are different. It's not just about the colour of our skin or certain other features, but there's and again, there'll be people who have evidence about this, because we've, you know, people have been able to actually look at our, you know, the last 10, 20 years, we can look at the whole genome. So but there's...
Do GPs have a way of going back to the GMC or the medical schools or the research departments and actually saying, this is what we observed? Is there any way, from what you've seen doing primary care on the cafes, going back and say, this is how we should be doing studies or research or anything?
Yeah. Well, I think those questions are being asked, or the points are being made, and from what I understand, because in a way, I mean, I see my role. I've always tried to see, okay, various people have kind of discovered stuff. My job is actually to put it into action and to, you know, kind of explain it and hopefully keep up to date with what, you know, the latest kind of expert opinion is, and to, you know, to some extent, I know what some of the discussions are that are going on amongst the experts. I mean, for instance, particularly, you know, on this topic, because people are, you know, there's loads of astounding mistakes that the medical community has made over the years, and I suppose so I mean, you know, for instance, when I was a junior doctor, you know, we always told parents to keep their babies face down, and then Esther Ranson highlighted some evidence that actually they were better off sleeping face up, and a lot of doctors like me were a little bit nervous about this because I've been a junior doctor. I'd worked on a kind of special care baby unit, and we always had babies this way up, but I mean the evidence was right, and now one kind of accepts the new normal, and I suppose the point I'm making there is that eventually people wake up, and I think there's a kind of a waking up to the the importance and relevance of ethnic diversity is I think is variable for some. So I mean, for instance, coming back to prostate cancer, I did a little bit of preparation, and roughly, as you guys probably know, in the black community, the risk of getting prostate cancer is twice as high as the risk of white people, but the risk of dying of it is twice as high, but it's not more than twice as high, if you see what I mean. So what I'm saying there is once you get prostate cancer, the treatment seems to be the same. Now, it's possible that there are some subtle differences that no one's spotted yet, but it looks like in that particular case, and talking about blood pressure, sorry, brother, talking about blood pressure, it has become apparent that there are some types of medication that, on average, work better in the black community than in the white community. The ones that work better in the white community do have some other advantages, and I have seen it written that actually doctors are being racist because they're depriving the black community of this one. I kind of get where people come from there. I think again this is where hopefully GPs can kind of individualise things so that it's not that you'd never give this one which doesn't generally work so well in the black community, you'd never give it, but if you've got to decide, okay, well, which one are we going to start with? But anyway, so I'm going down a slight rabbit hole there.
But you saying in terms of medicine, like reference in terms of that, should it be in the power of the GP to say, okay, this is a black man, this is more suited for you, you're a white guy, this is more suited for me. But what's happened now is that this is suited for everyone, but it's predominantly more suited for the white patient.
Yeah. So I think what the knowledge kind of develops. People ask questions which sometimes may be more or less challenging about, hang on, are you sure about this? What's about this situation? And the answer may not. The answer probably isn't something simple like, okay, we need to have two different types of medicine, one for the black guys and one for the white guys. So it's kind of like we need to identify. I think what are the differences and so I mean, for instance, we'll also kind of respond differently to men and women. We'll respond differently to older people and younger people. But we sometimes we'll kind of work on feelings a bit. But I mean, feelings are feelings. But what we want to know is that have some studies been done that will give information about this group compared to that group, or do we not have some knowledge? But let me pause there and come back to your question.
On the prostate, well, I was diagnosed with enlarged prostate a long time ago, and when I was first diagnosed with, I was given the tablet. I think it's Temulsin, two of them together. And I think and the purpose of that was, like, take for example, you see when I got up here, if I'm sitting and I need to go and urinate, And that was to help me. Without the tablet, I do not get a proper flow. So now they've given me this one I would call Combodart, in that sense, really. Now my question is it the combination of both of them, and will I have to keep taking that Combodart for the rest of my life?
Okay, so so you probably know, because you had a bit of information, but I guess one problem that can arise with the prostate is what we call BPH, benign prostatic hyperplasia, the prostate getting larger as the years go by, And that's one problem. Another problem is prostate cancer, and they're two different things. So nearly all men will get some BPH, and that can affect them more or less severely. As the prostate swells, the urethra, the pipe from the bladder to the outside world, kind of goes through the prostate. As it swells outwards, it also swells inwards, and it kind of squeezes on that, makes it narrower. As the urethra becomes narrower, the bladder is kind of working harder, and as the bladder is working harder, you get this kind of tendency to want to go more often. So there are two main types of medication that so one medication, the tamsulosin is one, kind of tends to relax the neck of the bladder and the kind of exit, and then improve the flow. And as it improves the flow, it kind of lets the bladder kind of work in a more relaxed way. So you tend to get, as well as improving the flow, you get less of that urgency, frequency, needing to go often. The Combidart is a combination of, I can't remember if it's tamsulosin or something similar, but works in a similar way with another drug called finasteride. So finasteride is a drug that tends to shrink the prostate. It kind of affects the BPH, and the finasteride work tends to take at least 3 months to have an effect, and it or maybe 6 months. If you stop taking it, then the prostate tends to start swelling again.
Yeah, because I've experimented and I've stopped a few times, and you see it's like you go back there, you said 2 to 3 months, but I've been taking it for a lot longer than that, well over a year now, probably even longer. So that's the second part of it. Do I have to take it for the rest of my life?
Yeah. Well, so when people ask me that, I suppose I quite often say, well, for the foreseeable future. But I mean, because in a way, things can change. I mean, so for instance, you might get to a stage in 10 years where the situation became that it was worth considering having an operation on your prostate to actually remove some of the prostate gland and open it up that way, and in that case you wouldn't need to take them. Or
the shaving, is that
well, yeah. So I mean, there are various techniques for doing it, but it's basically kind of cleaning out that channel a bit. I mean, another thing that, I mean, talking generally, I think because you've had the difficulty for quite a long time, it may not apply. But I think one thing, for various different reasons, doctors do tend to reach for the prescription pad or on the computer, perhaps a bit more quickly than we ought to, and I'll put my hand up to that. And so in this particular case, they may not think of some things like bladder training, which is that you, for quite often, not always, you can kind of train the bladder to relax a bit, and to kind of deal with that kind of problem that way. And I mean, I've only recently discovered a way of referring people for kind of general help with that, because bladder training isn't always kind of easy to do. It can help to have someone kind of talking you through it. But I guess for the time being, you're probably stuck with a Combidart. I mean, from another point of view, you can stop it, see what happens, kind of put up.
The new drug has been given for sickle cell.
Yes. Well, I think was this something I heard about, actually gene therapy? Or
It wasn't gene therapy.
No.
It was just a new drug I've
Yeah.
heard, but it's kept people out of hospital for the past year.
yeah, that rings a bell.
I'm just sharing that information because
Yes.
I don't know if people are aware of that.
Yeah, I mean, obviously, well, imagine if I vaguely heard about it, the sickle cell specialists know about it. I mean, particularly so. King's is one of the kind of national or international centres for kind of knowledge about sickle cell. I mean, really because of the local community.
Yeah.
I'm sure they know about it. I mean, Guy's and St Thomas's are not necessarily far behind them, but and probably they'd argue about who's top.
Before, because I'm kind of aware of time, just before we go, before you sum up, can you just name us the diseases and things that most like, we know prostate, we know sickle cell. What are the other diseases that are most likely to affect people in the Afro-Caribbean community? We said diabetes, we said prostate, we said sickle cell, we said high blood pressure, we said high cholesterol, hypertension. I mean, that's 6 so far. And then I'm losing count.
Well, yeah, so hypertension, high blood pressure, schizophrenia.
Yeah.
I mean,
okay, that's 5 then.
Yeah. I mean, I would say the important, well, yeah, I mean, you've kind of named, so, I mean, sickle cell is very important. Thankfully, it's not so common, but it's very important. I mean, in terms of kind of how common they are in the population, probably diabetes is top, then hypertension, then prostate cancer. Obviously, for the person with prostate cancer and you haven't got high blood pressure or diabetes, for you, it's at the top. I mean,
no, I'm just saying.
But in terms of other, I mean, you kind of caught me off guard, which I don't mind. That I'm struggling to name other ones. I don't know if anyone.
Dirk mentioned the ones.
I think
schizophrenia.
you kind of covered it though.
The schizophrenia is
another one.
Important.
Another one, and I had dementia.
Yeah. So the dementia probably links into the kind of vascular kind of what I call vascular risk. That is this kind of narrowing of the arteries. So obviously, so one type of dementia is where you know, again, there's just little bits of narrowing going on all over the brain, and that's vascular dementia. I mean, that actually Alzheimer's dementia has a different mechanism, but is commoner generally. I think probably there are other factors, or there may. So I'm not sure how much the extra amount of dementia in the black community is related to
because
vascular factors.
there's dietary and lifestyle issues in terms of contributions to dementia.
I'm hearing that sugar is contributing to dementia.
Alcohol too.
So I mean, So I mean, it can be difficult sometimes to untangle. For instance, I mean, is sugar more likely to give you dementia in itself, or is it because it makes you more prone to diabetes, and the diabetes causes more dementia? I mean, in a way, it doesn't matter. The bottom line is, you know, eat healthy, which means, you know, not too much sugar. I mean, again, it doesn't mean, you know, never have anything sweet. It means.
You didn't mention any any animal protein. You mentioned fruit and vegetables, low fat. But you didn't actually mention beef, any of the meats.
Yeah, no. Well, so I guess so think about meat. I mean, in a way, if you think what in nutritional terms, what's special about meat? The protein. But you know, when you eat meat, you're not just eating protein. You're eating fat and other stuff as well.
Yeah.
I mean, I would say in terms of cardiovascular risk. Then you know, you're better off eating chicken, preferably without the skin. That's low fat. So I don't really eat much meat, so I have to kind of think about it. Beef is good. I mean, lamb and pork are higher fat. I mean, pork's higher fat. Lamb is not so high. Beef is better. Chicken without the skin is best of all. I mean, just touching on meat, so processed meats, kind of salami and the stuff, something that smokes and so on. If people who eat a lot of that, there's an association with bowel cancer. but so yeah, from the point of view of the planet, it's, this is my view. The less meat we eat, the more plant-based stuff we eat, the better. And yeah.
Can I just have a couple more questions? I want to sort of summarize it because we've got Danny to have a bit of a break.
Obviously, you're a GP. You're a part of the medical establishment. But how does that? What am I trying to say? There's a lot of holistic, healthy health practices that people can try. Now, how does the medical establishment see those? I think the relationship's getting closer, but there's still an amount of skepticism. Can you recommend or warn against certain practices?
Well, I guess I would say, this is the point of view of one person, and I'm happy to be challenged, and I spent lots of time during COVID talking to people about vaccination, and as my colleagues advised me, and they were quite right, none of the conversations ended up in any of the participants changing their point of view, but on the whole we had a polite and intriguing conversation. But so I think there, for various reasons, the medical establishment tends to focus on kind of, I suppose, specific interventions, whether they're, for instance, very often some kind of drug, more often than not, but it might be some sort of operation, some kind of whiz-bang kind of heart valve replacement, or I was talking to a friend of mine who had angina, head, angiogram, and whatnot. They put this thing up your arm, goes into the little vessel in your heart. They do a balloon, and So when I was a medical student, I think there are a few weirdos who are just beginning that, but we kind of think that's normal. But the lifestyle things, I think there's been so for instance about exercise, there's been a lot of evidence for decades about how good exercise is for us, but doctors are useless at prescribing it, at promoting it, and I suppose people have got less sceptical about that. And at the moment, I asked a cancer specialist that it's very well established that women with breast cancer who exercise more are 25% less likely to get a recurrence of their breast cancer than women who don't exercise. The clever doctors don't know why that is, but they accept that it's true. And to give another example, you probably heard about people recommending alkaline foods. Now, the kind of scientific community kind of will say, well, that's a lot of hooey. I Googled this a couple of years ago. There's a kind of a mainstream scientific journal you may have heard of called The Scientific American. I came across a kind of interesting article, and the guy writing it kind of wrote this down, and what he was, so fruit and vegetables have a lot of antioxidants, which you've probably heard of, and one of the things that antioxidants do, the process of that kind of inflammation in the lining of the arteries that causes atherosclerosis, antioxidants tend to slow that down. Antioxidants tend to reduce the risk of cancer. If you look at an alkaline diet, it usually involves a lot of fresh fruit and vegetables, and the article went into a lot of science about and kind of apparently, with some foods, if you boil them, you end up with more antioxidants, and with some other foods, if you boil them, you end up with less antioxidants. But what he said at the end was that if people are following an alkaline diet and they're eating more fruit and veg, let's not argue about it.
The things like acupuncture and
Chinese medicine. Yeah. So I guess what doctors are always looking for is evidence, and I think one reflection is that in order to assemble the kind of evidence that doctors want to see, someone has to pay for the study, and the studies have to be worthwhile. So if you want to say, if you want to do a study on the benefits of exercise, there isn't a drug company who are going to pay you to do that study. And all that's involved in it. I mean, you know, well, Sports England might pay you, but I mean they're more interested in funding sports centres or whatever. So that's what doctors are looking for. And sorry, forgive me, I forget the exact details of the question.
You said acupuncture.
So acupuncture. So there's a kind of a medical framework that kind of understands ways in which acupuncture can work, and I mean there's a whole other area of chronic pain which I'm very happy to talk about. Got into that the last year or two, but I mean in a nutshell, the kind of stimulation with acupuncture kind of sends messages up to the spinal cord, and those messages can interrupt pain messages which are going up to the brain. So in that way, and actually my dad was an anaesthetist, and he used to do acupuncture sessions in this way. That was a long time ago, more than 40 years ago, and he was doing acupuncture. I'm slightly take a different point of view. He's also done courses in traditional Chinese acupuncture. So traditional Chinese acupuncture, the Chinese have a kind of system of 12 meridians that go through the body, which from a medical point of view make no sense at all. And I mean, as I understand it, and forgive me because I've never studied it. I've kind of gone through stuff. You know, it's about the flow of qi along these meridians and unblocking the qi, and your kind of gallbladder's connected to this toe, and so you know, people have done different studies. So but again, there's not really anyone in the acupuncture community who's got a lot of money to fund studies. So studies have been done, and you know and so I think quite often, I mean, for me as a GP, I suppose I've taken to saying, well, look, you know, this is my training. I don't necessarily know a lot about this. This thing I'd be cautious about because I can see a potential danger. This thing I can be cautious about because it's costing you a lot of money. But if you know, apart from that, you know, it's not my area. You try and see.
Could you touch on the fact that?
Can I just because that it's almost like 12:15.
Can I get a quick one in chapel? Just a quick one. Yeah, I'll come straight to the point.
Can we do it more of a generalized question instead of a generalized question?
Don't tell me to formulate my question, but what top you down?
No, you like a security waiting outside. Generalize it opposed to personalize it because it takes longer.
Yeah. Sorry. I just choked on my saliva, thanks to you.
Thank God it worked.
You know, going back to the beginning, when you started off, you started by saying that we could aim that each of us can go to a GP and more or less get a medical printout or what, and you give one example as to one reason why they would not give to you. Meaning to say if they don't know, they might say I picked this and that, and you said that might be what's the word, redacted or something like that. What other reason would they not give it to you? If it's about you, you must know about you or what you went in there for. So what other reason would they have for stopping it?
So the other potential reason is about kind of safeguarding. So I mean, for instance, the
sorry, safeguarding who?
Well, okay, so I'll explain. That if, for instance, a woman comes to me, and in fact, it doesn't happen very often, but she has a violent partner or coercive partner who may actually be coercing her through her NHS app to look at her records, I can kind of make those records not visible online, so that, I mean, that's the other kind of particular example. Or I mean, you know, it can get quite complicated to work out. You know, with in cases of sexual abuse, particularly when you're looking into it, you kind of don't want anyone to know, because sometimes you don't know who might be a perpetrator or who might not be.
So Doctor, you're getting confused with the two questions. The blood test, the question you can get that anytime, that's yours. What he's talking about is the NHS stuff online, and one of the things he said, like, if they're not 100% sure about a diagnostic, they may not want to give that information to the patient because they're not 100% sure. This is about, or the next step you're going into is like protecting person from abuse, which is common, and they won't give out information like that. For example, there's keywords. If your partner will go to hospital, keywords that person can say to flag up abuse in a relationship. So it's so I think you're talking about the blood.
No, I fully understand that. You know what you're saying, but it went there. So no, I wasn't asking.
What are the reasons?
Yeah, I just wondering, because the time when they brought you up, I was just thinking, say, if it's about me, using myself as an example, why would you hold it back? But when you give me and I couldn't think of any other example, because I was thinking, but now you mentioned what you said, it all makes sense to me. Yeah. And no, I knew I was asking.
I just want to hint on corruption in medicine, where the likes of Oxycontin was introduced in America, and they made millions, and it went through, through the corruption. It's harmful medication and supposedly pain relief, and they're overprescribed. And hold on.
I'm really trying to understand the relevance of the UK, because this is something that's not in his remit. You're talking about something that's a political thing, and I know what you're talking about. It's pandemic in America, but let's stick here. And I just want to wind there, because Danny's here to do his talk. And it's going longer and longer and longer, being very political.
Can I mean, I just kind of on a general point, I think, and forgive me, I mean, hopefully I've put this reasonably well. I mean, I think that my perception is that it's a fact that statistically, black people have worse health outcomes in the UK than white people. The reasons for that are complicated, but that's a fact. Some people in the black community, and I'm sure there's a spectrum from a little bit to quite a lot, are aware of that and other inequalities, and will kind of be very sceptical about what the establishment, which is largely white, are saying. So, I mean, I think these conversations are important. I mean, I mentioned COVID vaccination, and I mean, in a way, that's something which I think potentially has put kind of a bit of a wedge or a kind of a block in communication, or I guess it's a kind of a block in trust, really. I guess an undermining of trust, and I would say, if you take the medical establishment and individuals within it, there's a kind of range. I mean, there are some doctors I know I think could do with a lot of re-education, but I think the younger doctors and a lot of older doctors are kind of a bit more open-minded, but there's so I mean, I think what I'm saying is let's try and listen to each other. Let's be ready to unpick stuff and recognise it's complicated, and kind of maybe forgive each other, and I guess the people who, and there's probably is, in a way I'm talking to the wrong audience, because it's more the people like me who have the power, who need to be doing things differently. But I guess, and so forgive me, that really is digression, but you know, thank you for kind of having a conversation and you know, happy to do that. And I guess I'm just hoping that, you know, between us as a human race, you know, we can kind of you know, communicate, listen, explain, and get on. But let's go to Danny.
And can I just ask you to give that gentleman 5 minutes of your time before you leave? Okay.
This one?
No, this
one.
gentleman, because he asked about a problem earlier that we haven't addressed.
Okay. If you'd like to,
take a little 5 minute.
But anyway, sorry.
Okay, a 5 minute break. 5 minute break.
Should we have a 5 minute? Yeah, 5 minute break, and then we just.
Yeah.
And can we thank you for today?
Yeah.